And hello, we are live, I hope. Clicking over there to go live on that one. Too many things to click on. And we are live, I hope, are we? Yes, we are. Yes, we are. Hello, Dr. Juliet Balfour. How are you? It has been such a long time since we've spoken. It has, hasn't it?
It has. We've seen each other in real life, haven't we? But we haven't actually done a live together for ages. So I'm glad we're here.
No, that's true. I haven't been as organised as I should have been over the last, I don't know how many months, with trying to pull together so many things that your organising lives sort of went down the list. But now it's come back, and tonight we are talking, as you very much described it, dosing dilemmas and an awful lot of bleeding.
Yeah, absolutely.
People are bleeding to death across the nation as we speak. That's pretty much what it looks like from the messages that I've been getting, which is not fun. So where shall we start? Will we start with estrogen? Because estrogen is the thing that in the end makes that womb lining grow. So where are we at with estrogen doses, and why do we have recommended doses? We have a lot of people who take things outside of the recommended doses. Does that matter if they're not absorbing properly? How does it actually work?
So you're starting with a real big question at the beginning, Fiona, aren't you? Thanks for that. Okay, so we've got some new guidance from the British Menopause Society that a whole lot of doctors from the BMS, the Royal College of Obs and Gynae, the Royal College of GPs, the British Cancer Gynecological Society, the Faculty of Sexual and Reproductive Health, and some others, that everyone's got together to have a think about what to do about HRT and the fact that lots of people bleeding and that there's lots of different doses go on. So we actually now have a really useful chart that looks at all the different HRT preparations and says whether a particular dose is ultra low, low, standard, moderate, or high. And the highest dose is 100 microgram patch of estrogen or equivalent. So it should, we might be, I don't know, can we show people things on here or not, or is it too tricky, or we can post it somewhere?
If I had actually been sensible and put it up on my thing to share and present it, and could actually work out how to present my screen, I would. But can we?
That's what it looks like, and we'll tell you where to find that. But basically, so now we've got some definitions of what's a high dose, what's a medium dose, whatever, and which is really, really helpful. Now, some people say, "Oh, hang on, I'm on more than 100 microgram patch or equivalent," and this is becoming quite an issue because quite a lot of people are being put on higher doses, and yes, a few people, particularly young women who've had their ovaries out, some people will need to be on higher than low licensed doses, but we are trying, if possible, to keep people on licensed doses, or at least maximum recommended doses. So a few of the doses in that chart aren't actually the licensed manufactured doses, but we know from experience that they give reasonable general levels. But some women are sort of not, they're put on HRT for symptoms that may or may not be menopausal, and they're not getting better, so they're told to increase their estrogen, and they tend to go up and up and up with estrogen, possibly sometimes not leaving enough time between doses to actually see if the higher dose is going to help, because often we say leave it 2 or 3 months to adjust to a dose before you decide whether you need to go higher. But some people are going on much higher doses, and then sometimes people are doing estradiol levels to check and saying, well, look, okay, your estradiol level is still pretty low, so let's just go up and up your poor absorber. There's a bit of a problem with that, in that we don't think estradiol levels are very reliable. We've all had patients who are on a patch with a lovely steady dose, and we check that, and they're postmenopausal, so their own ovaries aren't working, and you check the estradiol levels several times and they're completely different each time.
Really? Would that vary on if they were using something on their arm and it was near where the bloods were taken, or what time of day they took it? I mean, was it consistently done with the same lab?
So there's so many different things. It depends, yes, what your skin's like, how warm your skin is, what you're using, when you, for instance, applied the gel, and when you did the blood test. Yes, we certainly see people with contamination where they're putting gel that goes up here, and then they're having the blood test and they have really high estradiol levels. So we are actually moving away from doing estradiol levels because we're realizing they're really not accurate, and we'd much rather just see how people go with symptom control. And the only proviso with that is if someone is, for instance, on a 100 microgram patch and they've still got loads of symptoms, we might check an estradiol level there, bearing in mind it's not terribly accurate. But just because if it was really low, like under 75, we think, well, okay, maybe just not absorbing that at all. But then instead of just going up in the dose, we would suggest trying another product, another brand of patch, or a gel or a spray, or if they're young and with no contraindications, oral estrogen, because that's sometimes absorbed better. It's such an individual thing. So, but there may be lots of people listening here who are on a very high dose of estrogen, and we don't really know what to do about the progesterone dose, which we'll get next thing we're going to talk about on those patients, because we haven't got the data. So it's a tricky one.
It is a very, very tricky one. The speaking of progesterone, then, so okay, we get to this point where we're on a certain amount of estrogen. We've got, from the number of messages that I've had come in today, basically I've got people who have just started HRT and they're bleeding all over the place, people who have been on HRT for a considerable period of time and they're bleeding when they're on continuous and when they're on cyclical HRT 10 times where they probably shouldn't be bleeding. And then we've got the postmenopausal people like me who continue to bleed no matter what. And so, yes, we've got a whole range of things out there. So let's start with perimenopausal people. If they're on, most I'm assuming will probably be on cyclical HRT, or they're, so they will be having a monthly bleed, most of them, will they not? So that would be kind of, if they're having breakthrough bleeding in between there, what are we telling them they should do? Should they even worry?
So basically, this is women. If they're still having the odd period, they've had the odd period in the last 12 months, we put people on sequential combined HRT. So that's estrogen all the time and the progesterone for half the month. And the idea is that they will develop a monthly bleed. That in itself could be tricky, because in the perimenopause, we know that women's natural periods can be erratic and they can get heavier or lighter, shorter gap or longer gap. So naturally they're going to have less regular periods. And then we add in the HRT, and it can certainly take a while. Sometimes people are then having 2 periods because they're having their natural period and then they're having a false period caused by when they're stopping the progesterone. And the problem with HRT is different to the combined pill. The combined pill can stop ovulation and stop periods, whereas HRT is not strong enough to stop natural periods. So some women get 2 periods a month, some people just get very erratic bleeding. But it's okay, we should be ideally, as doctors, warning people, it's okay to have erratic bleeding for the first 3 to 6 months after starting HRT, and for the first 3 months or so after if you're changing your dose or changing your product. So we don't worry about bleeding at that stage, unless it's absolutely horrific with pain and weight loss and lots of other symptoms. But it's okay, and it is common, very common, to get bleeding initially, because, as you mentioned, the estrogen is making the lining build up and the progesterone is trying to bring it down and keep it thin. But it can take a while for things to settle down. And we do try, if you're still getting fairly regular periods, we do try and get you to start HRT in sync with your period. So basically you would start your estrogen with the first day of your period, and you would start your progesterone on day 15, if you count day 1 as the first day of your period, and have it for 2 weeks. And one would hope that if you're then roughly taking it when your natural period comes, that it would gradually go in sync and you just have 1 bleed a month. But it doesn't always happen. And some people worry because they don't have any bleeding on sequential. And actually that's okay, as long as you're taking it fine. That's okay. It just means the line of the womb isn't building up at all. And then we can change people to the continuous combined HRT. So no bleeding is not a worry, but persistent, ongoing erratic bleeding is.
And in terms of that, I mean, how worried should a woman be? I mean, obviously all bleeding needs to be checked, but people sort of then seem to think, oh my God, I have to go in and have this checked. I will be dead by the end of the week. How realistic is it that they think that way? Because really the risk of it being something nasty is actually really quite small, isn't it?
It is very low. I mean, we always, before we start someone on HRT, we want to make sure that their bleeding isn't sort of sinister and doesn't need checking up. But if they were fine before, and certainly the first few months, we wouldn't worry at all. Hopefully, if we start people on HRT, we give them a review at 3 months, and we would always ask about the bleeding. And if it was bad, we could always then fiddle around with the progesterone at 3 months to try and improve it. And then if it doesn't settle and goes on, there's lots of adjustments we can do. And then if it's really not settling, then we think about investigations. Must just say that if there's anyone not on HRT, this is very different to what we call postmenopausal bleeding, which is when you're not on HRT and your periods have stopped. If you then suddenly have a bleed when your last period was over 12 months ago, that needs urgent investigation, because that is unfortunately more likely to be a cause of something sinister, or often a polyp. Polyps are incredibly common in perimenopausal and postmenopausal women. So polyps are common. Sometimes it's bleeding from the cervix, sometimes it's bleeding from the vagina or the vulva, but sometimes it is bleeding from the line of the womb. So anyone not on HRT who has a bleed more than 12 months after their last period, go straight to your GP and you'll be seen urgently to get that checked out. Still, it's far, far more likely that it isn't cancer, but it's something that needs to be checked out. And you're right that if you're on HRT, the bleeding is likely to be due to the HRT. So far, far more women are going on HRT now. And inevitably, a proportion of women, up to 40% of women on HRT, will get some what we call unscheduled bleeding. So bleeding when you don't expect it. But most of those will not. They still need to be investigated depending on what's going on. But most of them will not have endometrial cancer. So it's not really, really worrying. But we still need to discuss with each woman, find out what's going on. Sometimes you find things like their patches aren't sticking properly, or if they're on Evolcicri, which involves 2 different types of patches, they're just taking one out of the box and slapping it on without realizing that they should have 2 weeks of estrogen only, which is the Evol 50 patch, and then 2 weeks of the Evol Conti patch, which is the combined patch. Some women aren't realizing that, and then they're having erratic doses. And sadly, we do have some women who don't like the progesterone part of their HRT, so they reduce the amount that they use, and that can be, unfortunately, that's happening quite a lot, and that is dangerous, I'm afraid. And then we really would worry if you then have abnormal bleeding.
Yes, it's a difficult one. I mean, I didn't get on with it at all. It made me moody, gave me reflux. I really, really did not like it. So I can sympathize with people who do that, but also interestingly, it brings me to that point of tweaking your doses. Now, there seem to be more and more and more posts on social media basically saying that, yes, you should be doing that. I mean, it is one thing if you've got a problem with it and you need to change it, and you go back to your doctor and you say, okay, this probably isn't working for me. Should we fiddle around with the doses? But then when people are talking about, I don't feel good today, so I'm going to up this or lower that, then don't we get into a bit of a mess?
We do. It is very worrying what's happening on social media, and I understand. And some of these, the support groups are great in that, if people aren't getting answers from their GPs, or can't get to see their GPs at the moment because general practice is under such pressure, or maybe the GP's not sure what to do. I can understand why women are, going to Facebook groups and asking other people, but I do occasionally look on there, and some of the advice is wrong and dangerous and really worrying. So I would encourage people to try and talk to their GP, look on the Women's Health Concern website, look on the British Menopause Society website, look on the Primary Healthcare Forum, or Rock My Menopausal, or Menopause Matters. There's some good websites that have really good
information. The Menopause Research and Education Fund.
Oh, once we get some leaflets, we need to do some leaflets, don't we, actually, for that. But there is some good information out there. But I understand that menopause education for doctors is patchy. So we haven't, unfortunately, not every doctor knows quite what to do. But please, particularly don't increase your estrogen dose without discussion, and don't reduce your progesterone dose without discussion with a medical professional, because you could be putting yourself at risk of the lining of the womb building up and actually developing endometrial cancer. And we are seeing much higher rates of endometrial cancer, not because of HRT, but because we're all putting on more weight. And being overweight is a risk factor. There's various other risk factors: type 2 diabetes, polycystic ovaries. BMI over 30 is a bit of a risk factor. BMI over 40 is a very strong risk factor. And we would actually, if someone's got a BMI over 40, we would strongly encourage women to have the progesterone coil as their endometrial protection, because those women are at such high risk of endometrial cancer, and we don't want to add a bit more risk by them not having suitable endometrial protection. So that's what doctors, we're always going on about the coil. Is the Mirena, and there's levacerta and Benelexa. They're the 3 ones that are now allowed to be used for endometrial protection, and they are definitely the most efficient way of keeping the line of your womb thin, and they can even reduce what we call hyperplasia, which is the stage before endometrial cancer.
Why is increasing weight such a high risk factor for it?
Well, I think good question. What the actual mechanism is, I don't know. I mean, a lot of I don't know what it is. Why people are having higher estrogen with high weight? That's a really good question. I don't know.
Yeah, it's an interesting one, actually, isn't it? These are the things that keep me awake at night. Yes.
And there's a few other conditions, like some genetic things like Lynch syndrome and Carradine syndrome. They're genetic things that put people at a much higher risk of endometrial cancer as well. But then we are seeing women who are on massive doses of estrogen and not enough progesterone also who are having abnormal results.
Yeah. So that then brings us back to the progesterone, and let me start then with the Mirena coil. And I have somebody there who is asking, when we go to our GPs, sometimes things can be a little bit difficult. So basically, this person is basically saying, I've got a Mirena coil, I'm still bleeding, can I add progesterone or not?
So basically, when you have put a Mirena put in, it's not unusual to get irregular bleeding for the first 6 months, up to 6 months, really. That is quite common, and we usually warn patients. Then usually by 6 months, it settles to a light or acceptable pattern, or lots of people have no bleeding, which most people like. But it doesn't always happen. So you can certainly give people micronized progesterone on top, maybe for 3 months, to try and sort of stabilize the endometrium. Or the mini pill is another option, but it depends. I mean, if the bleeding's only she just had it put in the first month or so, we would tend to say, oh, just carry on unless it's too awful. But if it's going on more than that, certainly we can give short-term extra progesterone to try and settle things down.
And in terms of how much you would normally take, and this is another question, basically a lot of the GPs said, no, you've got a coil, you can't have any extra progesterone because you've got enough there. But in theory, what you're saying is that there is no great risk, because I mean, it's acting very locally. So is there, do we know if there's any risk of adding any more, I guess is the question.
So for those patients, it would be a short-term thing while things stabilize, settle down, the endometrium became thin, and then you could stop it. So yeah, there is a bit of a risk with progestogens. Yeah, so we know that so we've got the synthetic progestogens, which are the old-fashioned progestogens, and then we've got what sometimes called the body identical micronized progesterone, which a lot of people are on now, and that's Utrogestan or Gepitrix, and a lot of people like that because it's thought to be more, it is more breast friendly than some of the synthetic progestogens. But we do know there's a small increased risk with synthetic progestogens. So we now do have to warn women who go on the mini pill or the injection or have the Mirena coil that there is a small risk of increased risk of breast cancer, but it is tiny, particularly because we're dealing with a population, the young population, who are also at very low risk of breast cancer anyway. With combined HRT with women in their 50s, we know again that the combined HRT with the synthetic progestins does very slightly increase the risk of breast cancer, but it is very small compared to all the benefits of symptom control and heart and bone health. But the studies we've got so far indicate that if you're on estrogen and micronized progesterone, there's little or no increase in breast cancer for the first 5 years of use. This is starting from the age of 50, and then after that, it's duration dependent, but very small. So. And the Mirena, we used to think, oh yeah, the Mirena is just, it's in the uterus, it's acting locally, but some does go into the circulation. And some more recent studies have shown that Mirena has a slight risk, but it's small. And a lot of oncologists now say that if you get breast cancer, you have to have your Mirena out, and that's a debatable thing. So there's a little risk with progestogens. And then there's a sort of myth that orally estrogen through the skin is safer for the breast than oral, but that's not the case. The very small risk is the same whether with combined HRT, whether you have oral estrogen or transdermal estrogen. But yeah, going back to someone with annoying bleeding, absolutely fine short term, but you wouldn't necessarily want to have both for 10 years, but absolutely fine short term.
Yeah, yeah, because I think that one of them was saying she's had this coil now for 3.5 years and the bleeding has started, and the gynecologist said, okay, whip it out, get it changed, and have some Nutrigestin, and the response to that was no.
From the
So
Right.
yeah,
The what the gynecologist plan sounded. Obviously, I don't know the patients. I can't comment on individual patients, but certainly if someone is on the Mirena and is bleed free, and then they start bleeding towards the time it's running out, we often say replace it early. The Mirena is licensed for 5 years for endometrial protection. It's actually licensed for 4 years, but we're the Faculty of Sexual and Reproductive Health, so it's absolutely fine for 5 years. We do sometimes have people forget they get their Mirena put in. One common thing is if you put the Mirena in for contraception, if you're 45 or over, you put a Mirena in, that's it. You don't need any more contraception. So women hear the doctor say, fine, keep this into your 55, you're fine. They go on HRT and they use the Mirena for endometrial protection, but for that it only lasts 5 years. So they've got to remember that no, it's not lasting forever. I've got to remember how to change it every 5 years. That's really important.
yes, that is true. Very, very true. The I'm going in. When am I going? October, to have mine changed, which I'm not really very happy about because it's in the wrong spot, and
Oh,
because
no.
yeah, and because last year I dubbed the year of bleeding endlessly, and this year hasn't been much different. So but on one of the responses from one of the doctors who I was speaking to was, well, you can just go off HRT, and I was kind of thinking, why? These are the sorts of, I get so many comments of people coming in and saying that, and I was kind of, I mean, that's not a solution to the problem.
No, and it's really good. Now we've got these new guidelines. It's so good that they actually do say you do not have to come off HRT, because a lot of areas, until recently, every area had different guidelines. Our Somerset guidelines were, okay, if you have bleeding on HRT and you haven't just gone on it, or you haven't just had a change, obviously you need examining to check there's nothing else going on, and then you need a scan. And while you're having all those investigations, you have to stop your HRT to see if the bleeding settles. And if the bleeding settles, oh, right, it was obviously due to the HRT. And obviously it wasn't terribly, almost nobody wants to stop their HRT. And it was being very difficult, because then we couldn't investigate people because they wouldn't stop their HRT. But the new national guidelines do say you can discuss with patients, because some patients might not want any investigations or might be fed up and might want a break from their HRT. And if that's the case, fine. But if you want to carry on with HRT, that is also fine, and you don't need to stop it in order to get investigations. So that's a really helpful part of the new guidelines that we've got.
Yes, that is a helpful part of the new guidelines. All right, so let us go through these. Actually, no, I should have done this, because I've had a lot of people asking questions about, well, I'm on this dose, so does that mean I have to go up? So basically what we're talking about now with micronized progesterone is that if you are on a low to moderate dose of estrogen, then you would be having, if you were on, I wish I could actually read, continuous, you would still be keeping on the 100 milligrams. If you're on sequential, you'd up it to 200 milligrams, or you would have been at 200 milligrams anyway, wouldn't you? But then when you get to high doses, which are, where are we? High doses, moderate to high. So there's a gap here, by the way. There's quite a big gap. Moderate dose, 1.5 to 2 milligrams of Sandrina. High dose, 3 milligrams of Sandrina. What if you're on 2.5?
Yeah, we don't worry too much. Doesn't matter which way we go, to be quite honest. So just quickly, for those who don't know, we've talked about sequential HRT. Continuous combined HRT is when you take estrogen all the time and progesterone all the time. And we start people on that if they haven't had a period for at least a year before they start HRT, or once you've been on it, once you've been on sequential HRT for years, we change you over to continuous combined. And that's designed not to give you any bleeding, but again, quite a lot of people get erratic bleeding for the first 3 to 6 months after being put on continuous combined. And also, certainly if you were changed from sequential to continuous combined, we wouldn't worry about bleeding in the first 3 months while you're getting used to continuous combined. So that's just a general point. So yeah, why these new guidelines? So basically, lots and lots of women now had a massive increases in the number of women who've gone on micronized progesterone for their endometrial protection, partly because it's most breast friendly, it's good metabolically. People tend to have less progesterone side effects, but that's certainly not always the case. So we've got loads of women on it. And sadly, we've realized that micronized progesterone isn't as good at controlling endometrium as we thought it was, sadly. We know, all the studies were done on standard doses of HRT. So actually, most of the studies were done on a 50 microgram patch or equivalent. So that's 50 microgram patch, 1 milligram Sandrina, 3 sprays of Lenzetto, or 2 measures of estrogel. So most studies are done on that. But now we've got lots more people on higher doses. And again, as I said, we've got lots more people in HRT generally. So all these people got together and thought, well, what are we going to do? How are we going to stop all these women getting bleeding, the incredible anxiety it causes with everybody thinking, oh my God, I shouldn't be having this bleeding, I've got cancer. The complete overwhelm of our gynecological services, who are spending all their time seeing these women with bleeding on HRT. So the ones who actually everything's getting delayed, the routine gynae is getting delayed, it's had a massive issue all around the country. So that's why they thought, right, what are we going to do about it? And they had to work out what to do. And so as you say, what they've worked out, so the first thing is, if you're not bleeding, if you're fine, if you're on the 100 microgram patch, 4 measures of estrogel, 3 milligrams Sandrina, if you're on those and you're not bleeding, next time you have an HRT review, or next time you're contacting the doctor, you need to discuss increasing your micronized progesterone. And if you're on sequential, you go from 200 milligrams for 2 weeks out of every 4 weeks to 300 milligrams for 2 weeks out of every 4 weeks. And then if you're on continuous combined, you go from 100 milligrams every night to 200 milligrams every night. Or you drop your estrogen dose down a bit if you don't particularly want to do that. So obviously some women get side effects on micronized progesterone, which would be worse if they double it. Some women would rather not go up, and we haven't got the research on this. There isn't any evidence, but we know we've got a problem. We've got to solve this unscheduled bleeding problem. We don't know what doubling the progesterone does to breast cancer risk. It may be absolutely fine. We just don't know. It may be a dose effect, or it may just be the molecule doesn't do it. So we can't say definitively it's absolutely fine to do it, but it seems to, a lot of people seem to get on well doing that. And but yes, another option will be just to drop down. So if you're on a 100 microgram patch, you could drop down to a 75 microgram patch. And in fact, lots of women find they're absolutely fine on the 75, and then they don't need to double their micronized progesterone. So that's the group who have no problems that we're.
So basically, if they've got no problems, they go along for this schedule. And if they've got no problems, why can't they say, well, I've got no problems, I don't want to up my progesterone? Do they have to?
Well, yes, they do, because they might be, we don't know what's going on in their womb, and they might develop problems. So we don't know whether their womb is quietly thickening up and it just hasn't bled yet. So unfortunately, every woman who's on the maximum suggested dose needs to at some point have a discussion with their doctor about whether they're going to drop their estrogen a little bit, or change to a different method and see if they get on better with that, or increase their micronized progesterone dose, or change to the Mirena. They could just go and have go and have a Mirena, and I know it can be a bit complicated finding somebody to do it, or they could change to the combined patches. So the combined patches have got estrogen and a synthetic progesterone in, and they've got the right amount of progesterone for the estrogen, and the synthetic progesterone is actually often better at keeping the lining of the womb thin. So if you're on one of Evelconti or one of these other combined patches, you don't need to worry about increasing everything. The only thing I would say is we do see people who are on Evelconti or equivalent, which is a 50 microgram dose, which is a standard dose of estrogen, and they think they need a bit more estrogen, so they get something else, like they put an extra patch on, or they put some extra estrogel on or something. But that unfortunately is not safe, because the patches have got the right amount of progesterone to protect the line of the womb at the 50 microgram dose. But if you go higher on the estrogen, again, you're not protecting the womb enough. So unfortunately, you can't do that. So that's the group which don't have problems. The people who are having prolonged unscheduled bleeding, i.e. they've been on their HRT for 3 to 6 months and it's not settling, or they suddenly start bleeding having been fine, then those people we might up the progesterone at a lower dose. So even if on a 50 microgram patch, but they're just bleeding's not settling, we might up the progesterone at a lower dose. And also, if someone is very overweight, we'll have a lower threshold for upping the progesterone dose at a lower dose. As with lots of these things, it's very individual.
Yeah. So just let me just recap on that a little bit. So if you say like only on a, let's say, okay, so I've now dropped my Sandrina down to 1 capsule. So let's say I'm on that, and I'm not having any problems. So when I go back for my next review, can I just carry on like that, the way I was with my 100 micrograms of Utrogestin and my 1 sachet?
Yeah. So it's only if you're on the maximum dose. Which we can these charts, by the way, if you go onto Women's Health Concern website, and they've got lots of patient information sheets, and there's a new one there called Unscheduled Bleeding on HRT, and it's only 3 pages, unlike the document for doctors, which is 47 pages. It's just a 3-page document, and it's got the table that Fiona showed you, and it again like that's the one. Yeah, there we go. It's the doctor's one, that's the patient's one. So it explains about unscheduled bleeding, and you've got those doses there. You can have a look and see what your dose counts at, which is quite useful. So it's very much a question of, with the bleeding, if you are having some bleeding, we have to talk to you, find out what's going on. I say check you're using HRT correctly, look at your weight, your family history, all sorts of things to work out whether you need sort of routine-ish investigation, or whether you need urgent investigation, or whether you just need an adjustment of your progesterone if you haven't been on it very long. So we can't give blanket advice about what we do with each person, because it is very individualized.
Yeah. People from outside of this country may be looking in and thinking it's kind of a knee-jerk reaction to change your guidelines to help manage a congested system. Is that an unfair criticism?
I don't think so. I think it's to manage a congested system and an awful lot of patient anxiety and an awful lot of medical hours trying to sort this out. And we are, in the long run, yes, trying to stop increased rates of endometrial cancer. Where you could certainly think is, there is a lack of evidence for what's being suggested, but that's the case for an awful lot of women's health and menopause care. So it's trying to, and that's why it wasn't just one group of people saying do this. It was this whole conglomeration of lots of experts sitting down for many hours to try and work out what's the best way through. And a lot of centres are doing research, and the new guidelines are kind of what we call live, in that they're going to be adjusted. When we get more research through, they're not set in stone. Hopefully things will change, but at the moment I think it's important to have a cautious attitude, because to try and keep people safe and less anxious, and yes, absolutely help a struggling gynae system. But your trouble is, if gynaes are overloaded, those women not on HRT with postmenopausal bleeding who've more likely got endometrial cancer are going to get wait longer. So it's tricky. But I don't think any other countries, actually no, I think Australia has upped their micronized progesterone doses, haven't they? I think
they have very much, yeah, but they are starting to see the same trend in increased bleeding. So I think they're sort of thinking of, I interviewed Rod Baber about it a little while ago, and he was saying that the similar things are being seen, but I don't think that they, I might be out of date. I could very well be out of date. They may have made a change since I last spoke to him. But the impression I got was that they thought it was too early.
Right, yeah. So we shall see. And as I say, the guidelines will change with time, but the gynecologists were just tearing their hair out, I think, and there's no doubt, it is very anxious mating, and this partly being done to reduce patient anxiety, with trying not to change, sort of decrease patient safety, really, because before, everyone with bleeding on HRT was going on the 2-week wait, the urgent cancer pathway, which is, so now it's been sort of, you work out, depending on risk factors and history and all sorts of things, the guidance for doctors, there's lots of charts and flow charts and stuff, is to work out small number of really high risk people need to go on sort of urgent cancer pathway, and then lots of them go on a sort of more see within 6 weeks pathway, and then lots of people actually won't need investigation because we'll be changing their progesterone and stopping the bleeding, and they won't even need investigation. So so yes, doctors have got this massive document, 47 pages long, that you can access on the British Menopause Society website. But there's something called Getting It Right First Time, which is a group I didn't know of, and they have done a 7-page summary, again, which patients could look at as well if they want to, of the new guidelines, which it'll be easy. And in fact, they're going to UCL are designing an app so that doctors will actually be able to put in the details of an app and then be told what to do according to the guidelines, which will be amazing, because obviously we all know how busy GPs are. It'll be fantastic if they've got something to help them navigate what to do quickly.
Yeah, absolutely, because it's a big responsibility in a way to bear, to make all of these decisions as well, which is because you obviously don't want to be wrong.
You don't want to be wrong. Absolutely. And the great thing about general practice is you can say, if something's getting worse, come back. If someone's following the guideline, but in fact they then have a massive bleed, or something happens, then we can always change tack. But it's really helpful to have these guidelines, and it's really helpful that people don't have to stop their HRT, because that was causing so many problems.
Yeah, exactly. And so, all right, so we've upped the progesterone. How long are we giving it to settle before we think we're in the clear, or we're coming back going, no, this isn't working?
So we normally do adjustments to 3 to 6 months. I mean, if someone is, again, one would be looking at risk factors. So if someone's very overweight and it wasn't settling quickly, it was getting worse, one will probably move further. But it certainly, if changing things around after, if you've decided they don't need urgent investigation or soon investigation, and you're just fiddling around, you're cleverly, expertly altering the hormones, we would give it 6 months. And if it wasn't settling, you would then look at the protocol and sort of arrange further investigations again. Yeah.
A couple of questions that came in for people not related to bleeding, and one was actually, if you've had your ovaries removed and your uterus, can you have progesterone? Would you have progesterone? Are there any reasons why you would?
This is interesting. This has been rumbling around since the 1960s. There's been the occasional, not the odd, that would be the occasional professor or doctor who sort of talked about how brilliant progesterone is and suggesting it for all sorts of things. The data we haven't got data to show it is beneficial, but it's definitely out there on social media now that people are talking about it. As someone who spends an awful lot of my time in menopause clinic trying to help women who absolutely hate their progesterone, it seems a bit strange to me, because most people would much rather not take their progesterone. The one sort of group, I mean, there's the few groups that we would potentially talk about continuing progesterone. So if someone's had a hysterectomy and they're ovaries out for endometriosis, and if the gynecologist has seen a lot of endometriosis in the pelvis and they can't remove it all, and someone wants HRT, we often give progesterone as well, because if you give estrogen on its own, those little pockets of endometriosis in the pelvis may well be stimulated and flare up and cause ongoing problems. So that group of women might have progesterone. There's another group of women who do find that a micronized progesterone calms them at night and helps them sleep. So if someone is that situation, I potentially would say, okay, yes, let's have it. Realize this is off license, it's out of guidelines, but it really helps you sleep. It's much better having that than a addictive sleeping tablet. So yes, maybe for that. But for other women who've just heard on social media that it's a good thing to do and it's really good for them, I really would say, well, we just haven't got the evidence for it at the moment. And as I say, most people hate it anyway. But so we'll see. It's be interesting to see what happens with that, because I think it's comes in and comes out again. People hear about this thing and it becomes a bit of a fashion, and I've certainly had people asking me about it, and then it potentially goes away. But I've seen a few women in clinic who were seen many years ago by one of these doctors who was advocating progesterone, early HRT, and they've come back with osteoporosis and heart disease and because they didn't have the estrogen which they need, would have helped with their bone and heart health. And I think, oh, it's tragic. They've missed out on the estrogen part of HRT. So, but who knows? Someone may come up with some amazing paper with showing amazing results, but who knows? But it hasn't happened yet.
Yeah, because my next two questions were, what about people who want it for their sleep? Can they have it? And the other question was actually somebody who was writing and saying progesterone alone in perimenopause, is it a yes or a no, and how do you manage it? And I'm guessing what you're saying then is that basically, no, it's not necessarily a great idea, because I think there are a bunch of people who will argue that progesterone does amazing things for vasomotor symptoms, and yes, it has a role in muscles, and yes, it has a role in bones, but obviously from what you're saying, their role isn't significant enough.
We certainly haven't got the research. It's certainly not something that any of the societies I'm a member of have advocated. But who knows? Who knows? They may discover things like that. Who knows? But and certainly, some people are using high doses for management of PMDD. But again, that doesn't particularly make sense to me, because tends to be an intolerance to your own progesterone that causes you these awful PMS or PMDD symptoms, and sometimes we treat that by suppressing ovulation, so you don't then have the progesterone surge. So and we can sometimes with severe PMDD, if the best thing for them is to, if you can, is to take the combined pill, because that stops ovulation. But if you can't take it for some reason, sometimes we'll give 100 microgram estrogen patch to try and sort of flatten the hormones, but you still have to have your progesterone as well. But yeah, progesterone is what you found with your micronized progesterone. Lots of people absolutely hate it, and the thought of taking it without the benefits of estrogen, the vast majority of people, I don't think, would want to do that.
True. And I guess the corollary of that, or the opposite of it, is in the end is a progesterone cream, because I've heard a lot of people saying, well, I'm now getting a progesterone cream, it helps me with my mood, and I think there are absorption problems with progesterone in a cream, aren't they? It's a quite large molecule, and it doesn't seem to get across the skin barrier unless it's in a specific formulation. So are they putting their endometrium at risk if they're relying on progesterone in a cream?
If they're using HRT and they're using it for endometrial protection, that would be a massive red flag, and that would be an urgent scan as soon as we found out that's what you were doing. Because yeah, you're absolutely right. The synthetic progestins in the patch, they're absorbed through the skin, but most other things aren't. And unfortunately, micronized progesterone, they can't make it into a formula that will go through the skin. So it's oral or occasionally offline, it's vaginal. But no, the progesterone creams, there's quite a lot of them, and I think certainly I think progesterone can help slightly with some symptoms, because I've certainly noticed women with a Mirena coil find that hot flushes go, and then you take the coil out and get more hot flushes. So I'm sure there's a little bit there that progesterone can help. But yeah, you certainly couldn't rely on the progesterone creams. And there are so many things being sold to menopausal women now. I'm afraid it's just, meno washing is rife. So with all the supplements, and I read what they said. Oh, that sounds good. And I always find myself getting sucked in. I think, hang on, that's not a thing. But the pseudoscience around some of these advertisements and things is worrying, and we know women are desperate, and they're spending an awful lot of money, hard-earned money, things they can't necessarily afford, because they're so desperate to find things that make them feel better.
Yeah, absolutely, and they are. And yes, it does. It never ceases to amaze me. The couple of things that have really annoyed me recently is the advertising of weight loss injections for menopausal weight gain. That's made me very upset, because I think it just sends a really awful message about menopause. That is just, yes, a lot of us might put on around about 10 kilos, but that's not going to push all of us into a BMI above 30. So I don't know. I think it's sending a very bad message about menopause weight gain. So that made me very unhappy. But the other thing that is trending, as they say, is all right, what's your view on this one? Should we be putting our estradiol cream on our face?
Well, so there's some American
it's gone crazy over there.
Yeah, so they have actually produced a cream that goes on the face. I don't think we should be using the preparations we've got at the moment.
You certainly wouldn't want to put your Sandrina on your face.
You certainly wouldn't want it. I know. I certainly wouldn't recommend it, but I think someone will create a cream, a face cream with estrogen in it at some point soon, because and I don't know what trials the group in America did. But
I think they're relying on historic ones. I listened to a podcast about it the other day, historic ones where basically, people they'd done double butt cheek tests with a placebo on one cheek and an estradiol cream on the other, and compared the two and found that there was sort of very little systemic absorption, and it was all perfectly safe. And again, it made brilliant butt cheeks. Well, one was really good and the other one had to catch up. But that, I think, is a vastly different thing from slathering it over quite a large area and then on putting it on your hands, and then you're thinking, oh, you know what, it's got to go on the chest as well. And it's another thing to do it for short term, and then or compare it with safety data from using it vaginally twice a week as opposed to on a large surface area every single day.
It'd be a real worry. So it may well come, but we know that taking HRT, systemic HRT, the traditional ways, we know that helps stop our loss of collagen. We know it's really good for skin and hair, and we never give HRT purely for cosmetic reasons, but we know that one of the benefits is that it helps our teeth, our bones, our hair, our skin. So I think if you're on HRT anyway, you don't really need to think about anything extra for your face from that point of view, apart from sunscreen and all the other things. If you weren't on HRT and then you were using it on your face, I'd be very worried about absorption and what was happening to your endometrium. So I think in this country we're going to have to wait and see whether some drug company decides they want to try and tap that market.
It's already here. There are a number of people doing it. There are a number of websites here of people who do compounded products who are selling it.
Really? It's
here.
Yeah.
It's here. But the other side of that is one of the side effects that they did find from these tests was that there was breast tenderness. So how can you say there's no absorption if you've got breast tenderness?
Absolutely. So interestingly, obviously we know absorption from vaginal estrogen is very low, but when you first start, if you've got very thin vaginal vulval tissues and you start using vaginal estrogen, some women do get symptoms like breast tenderness to start with, because the walls are so thin that more gets into the circulation, you get side effects. And as the vaginal walls thicken up, you then, it doesn't let much through and you don't get systemic side effects. But potentially that's not going to happen with the skin. Potentially if I could imagine you carrying on get breast tenderness, which would indicate ongoing systemic absorption. So it's a bit worrying, isn't it? It's a bit worrying. And obviously you mentioned compounded, we really don't recommend compounded, what they call bioidentical HRT, which is you have lots of expensive tests, urine tests, saliva tests, you get told what you need, and it gets sent off to a compounding pharmacist, and you get all sorts of hormones, not necessarily extra ones we don't necessarily need, and it gets made up into a special formula for you. Incredibly expensive. You have to have ongoing blood tests, and some of it will be good, some of it won't. We just don't know what's in it. Sometimes people aren't having enough endometrial protection in their combinations. They've been given extra stuff they don't need. So if you are on compounded bioidentical HRT from a very expensive from a private provider, might be worth you talking to NHS GP about swapping over to the NHS products, which are body identical, but and we know what's in each thing. Yes, there are sometimes issues with particular brands or particular products now and again, but basically they are a lot safer than the compounded bioidentical HRT. The names are really confusing. So we say regulated body identical HRT or compounded bioidentical HRT.
Yeah. That dosing thing is the pumping thing is still a bit of an issue. So I see people are still not getting the same amount out of each with each pump.
It is an issue. It is a big issue. And as some people are saying, a brand of patch, it's changed manufacturer and it's not sticking as well. So there seems to be a constant, people, it's tricky because you can take a long time finding the right preparation for you that works for you at the right dose. And then, hey presto, it's discontinued, or there's a shortage, or the manufacturer changes and it doesn't work so well. And I appreciate it's incredibly frustrating for women when this happens, but it seems to keep happening, doesn't it? There's one thing after another. And we had that shortage of E-string. That was a nightmare.
Tell me about it. My favorite thing, thanks to you. Yes.
Yes.
Yeah. That seems to be settled now. I think they're back in stock. I think, aren't they?
Yeah. For anyone who doesn't know, estrogen is vaginal estrogen. It's a lovely little ring that you just pop in your vagina and have changed. You just change it yourself, actually, if you can, once every 3 months. It produces there we go, a slow, steady dose of vaginal estrogen to help with vaginal and urinary and vulval symptoms. It's not HRT. It's just local vaginal estrogen. So that's called the estrogen that Fiona and I both love. And there was a shortage for a long time, wasn't there? It was quite long. But let's hope that we get better supplies of things, and that manufacturers listen when we say that things have changed as well, because I think a lot of women are doing these yellow cards into manufacturers saying something's changed, but it's not necessarily looked at. So hopefully that will improve.
Yeah, I did an FOI a couple of months back actually on it, and the number of complaints had dropped considerably, but there was still a consistent set of complaints about symptoms returning and not equal pumping.
The other interesting thing is that I see a lot of women who are great on HRT and then their symptoms are returning, and sometimes it's because their estrogen receptors are down regulating, because maybe there might be a little bit too much estrogen for them anyway, so they're still on the same estrogen, but they're getting more symptoms back because their receptors are down regulating. They can up regulate and down regulate apparently, which is very interesting. So that's a big worry for people who are on massive doses of estrogen. They sometimes their receptors down regulate because there's so much estrogen around. So then they need more and more estrogen to get an effect, which is why we see people going higher and higher and higher with their estrogen. I mean, this isn't going to apply to everybody, but there's a lot of complex things going on in our bodies when we're on HRT. It's not as straightforward as we would hope, really.
Do they re-up-regulate themselves, or is this sort of like is this the equivalent of insulin resistance? You've knocked on the door too hard, too many times, and it's just not opening again.
That's a very good question. We don't know. And then and when we're starting HRT in older people, what are their estrogen receptors like? Have they given up? Can they be reactivated? We don't know. There's so much more research to be done on all this.
True, and that's another interesting thing about the estradiol on the face. What they found was if you had some damaged skin, it really didn't work. So I'm guessing somewhere in so they got better results on a butt cheek than they got on sun damaged areas. So I'm guessing then that the sun damage must also do something to the estrogen receptors.
Right, maybe.
Who knows? We are complex beings.
We are. It's not straightforward, and that's why it does take a long time, to try and get people better. And as we always say, it's not just all about the HRT. You've got to look at your lifestyle, and it's so important. You've got to look at your exercise and your stress levels and your sleep and your nutrition and not smoking and not drinking alcohol. All these things are so important. So yes, the HRT can do so much, but then you've got to look at other things.
Absolutely. Brilliant. Right. We have digressed. Is there anything that we need to pump home with the progesterone, HRT and bleeding, or do we
so I think just go on the Women's Health Concern website, patients, and have a look at the information leaflet all about that and have a read through. And some GPs won't. We're trying to do lots of education, but GPs are very, very busy. GPs might not have sort of come across this. If they don't know about it, just take when you go and see them, or give them the leaflet, or if you talk to them on the phone, tell them where to get that leaflet. If they want to know more, then there's lots more information on the British Menopause Society website with the 47-page guideline and the 7-page summary. So if everyone needs to be spreading the word on this, because it takes time for this sort of information to come out, and obviously we can do education sessions on it, but obviously I tend to find it's often the keen people who come to the educational sessions, and they come to all my educational sessions, and then there's a vast majority of people who don't know, aren't so up to date. So you can help your GP by if they look completely blankly at you, then show them that chart.
Yes, absolutely. Or send them to the Menopause Research and Education thing, donate £15, download the whole day's worth of course, which includes a whole session on those updated guidelines.
Good plug, Fiona. Absolutely.
I'm doing good at this now, actually, aren't I? Very good. Yes, so remember to subscribe as well. All of the things my husband keeps telling me that I have to remember to do. Brilliant. All right. I shall let you go then. Thank you so much for that. And hopefully we shall talk again in the not too distant future. I will be better at organising things.
No, it's lovely to see you again. Okay, bye.
Bye.